Hello and welcome. My name is Kerri Maya, and I'm here to share my call to awareness, surviving the trauma of delirium, why I am passionate about delirium care for patients and families. In March of 2020, the Global Council on Brain Health published a key report on the impact, prevention, and treatment of delirium, which identified that this is a highly prevalent problem, affecting as many as half of hospitalized Americans 65 and older, or 6 million people per year in the US. It is associated with many severe short-term and long-term sequelae as well. The report summarized the impact as the 6 Ds of delirium: distress, death, duration, dollars, dementia, and loss of dignity. But what is distress and delirium? Williams et al. Defined it as anxiety, depression, and post-traumatic stress disorder symptoms resulting from a delirium episode. Ortega explained that psychological distress that is related to uncertainty and helplessness, perhaps a sense of vulnerability while in our care. And Grover and colleagues identified that among the various symptoms, the presence of delusions was the most significant predictor of patient distress. But distress is not limited to the patients alone. Distress and delirium can affect the family as well, in terms of psychological consequences of experiencing or witnessing disturbed episodes of altered reality in a loved one. Quite simply, the lived experience of delirium is often a form of trauma. Ortega in 2020 provided a vivid description of this lived experience, stating that it was the omnipresent feeling of fear related to the possibility of death. Having such a description helps us recognize that distress and delirium truly is a symptom of trauma, as defined as an event or set of events where an individual either experiences or witnesses circumstances where there is an actual or threatened death or serious harm. And the consequences of distress and delirium are severe. 80% of the patients that remember their episode of delirium report severe distress. Post-traumatic stress disorder is experienced by 1/3 of delirium survivors. These are debilitating psychiatric symptoms, such as severe depression or anxiety, that can be experienced in up to 62% of intensive care survivors with post-intensive care syndrome. And again, this distress is not limited to the patient, as 30% of family members develop post-intensive care syndrome family, or PICS-F, which is the impaired psychological health after a loved one discharges from the intensive care. So what can we do to improve distress and delirium outcomes? First of all, we need much more research. Currently, we do not have a standardized distress and delirium assessment tool that is appropriate for acute care populations. Nor do we have standardized strategies for non-pharmacological distress interventions for acute care that are appropriate for this population. If we had both an assessment tool and standardized interventions, we could then move towards trauma-informed healthcare strategies. On the education side, we also need to provide psychoeducation for the patients and family about what is delirium, what is distress and delirium, what is known about how we can prevent it or mitigate it, how we can help support these families across the continuum of care. This requires that healthcare team members have awareness of distress and delirium and the outcomes specific to this distress, and engage in advocacy strategies. perhaps one of the most powerful advocacy strategies is to be able to share our stories. For me, my story started as a daughter, even before I had recognition as a critical care nurse about the importance of delirium. Over a decade ago, my dad had what seemed like a minor heart attack, and he went to the emergency room of a well-known, world-renowned teaching institution, where he was, with all purposes, going to receive the absolute best care. My dad was terribly, terribly frightened, though. And really, this fear was building within him to the point where he said to us, "I am leaving this hospital one way or another, even if it's in a body bag." This was the last thing that my dad shared with our family before he was taken to the cardiac cath lab. And unfortunately, not too long after arriving there, he did code, or his heart stopped, and the medical team had to resuscitate him. This was a very lengthy and difficult resuscitation. When the doctor finally came out to talk to my family, he was splattered in my dad's blood and visibly shaking, and he said it was the worst resuscitation of his entire career. And yet somehow, just barely, they had managed to get my dad back. He would be going to the intensive care unit on a ventilator to help with his breathing and on a balloon pump to help with the function of his heart. From that point forward, the team seemed very focused on how my dad's heart was doing, the fact that they saved him, and his heart seemed to be recovering. There was no recognition of what my dad's experience of reality was like and where his mind was at. Unfortunately for my dad, his experience of reality was that there was a nurse person and a doctor person, but the doctor never talked to him, and neither the nurse nor the doctor ever explained what this equipment was that was attached to his body. He also knew that he was being withheld from his family, as there was very limited visitation policies in this ICU at that time. And so he was left to come to his own conclusions. And of course, naturally, he came to the conclusion that he had been kidnapped by the bedside nurse and taken to her basement, where they were conducting archaic medical experiments on him. They were torturing him and holding him prisoner, both with physical restraints and chemical restraints. This my dad was very, very sure of. Eventually, my dad's heart did recover, and he was able to discharge home. But unfortunately, since nothing had ever been done about the state of his brain and his mind during this time, he was still discharged in a state of delirium or acute brain failure. And for him, his reality was one of an ongoing nightmare. He was completely convinced at that point that he was dead and that everything he was experiencing was just a piece of his afterlife. Being a family member, we felt entirely helpless. How do you help a loved one recognize that they are still alive, that they can still engage with life, that they were given a second chance, and to make the most of that? If you told my dad the real story, he would logically agree with you. Yes, he had been resuscitated in the cardiac cath lab. Yes, he agreed. And yet the emotion of that nightmare just kept on washing over him again and again and bringing him back to the conclusion, but he was dead. This is true suffering. True suffering for a patient, true suffering for a family, and suffering that nobody should have to experience. Share your story, because storytelling promotes change. It can unite us in our shared purpose. Stories are authentic ways to share our lived experience with others and to inspire more people to heed the call to action. What is your story? Why are you passionate about improving delirium care? And how can you inspire others to be equally as passionate? And remember why awareness and advocacy is so important, because we cannot turn our backs to other people's suffering. Thank you for your time.